a great pleasure to meet you again, especially during this hard time, and even if virtually. And thank you again for your very kind words. And my talk today is about management of complication and endoscopic pituitary surgery. So it seems for me more relevant to speak about pitfalls and how to avoid complications in endoscopic pituitary surgery, and therefore their management. What's happening? Here, my university, Rabat, I'm working Abul Qasis University, and my hospital here, Sheikh Zayed Hospital, when I work in Rabat from more than 10 years ago. So we were interested to see how to reduce the complications by following the different steps of the procedure and taking into account the experience accumulated in endoscopic pituitary surgery, and highlighting the message to remember to smooth the learning curve, avoid complication, and those, of course, improve results. So today, as already said by all my predecessors and my mentors, we should consider the endoscopy as an important tool in the armamentarium of the skull-based surgery. And as you know very well, and repeat by all of you during this session, and also during this weekend, during the endocrine WFNS endocrine neuroendocrine committee, the endoscopy pituitary surgery has emerged as a better alternative to microsurgery. Paulo showed us very well the advantage of course of endoscopy regarding the microsurgery. Has distinct advantage, provide better visualization, avoiding functional disorder, respiratory chain, rhinitis, etc. This technique needs endoscopy anatomy knowledge. It's very important. It's emphasized by many of you. And the learning curve with the ANT, in my humble opinion, is very, especially on ANT endoscopic surgeon, is very important to start this approach. So we need more than 50 procedure from my view for pituitary adenoma to control, to master this approach or more. And the selection of the patient is very important for successful outcomes, especially in the beginning. So they are summarized in the following schema. The microscope provides a tubular view, as you know very well, whereas we have a panoramic one with the endoscope. Illumination and magnification are better. It's a panoramic, wider view, close-up view with endoscopic, as you know very well. And this is a better distinction between tumor and normal tissue. We show us that many presentation, and looking around the corners, we see what our friend from Japan to show us how he can go from cella to cavernous sinus below, but we need to know very well, to have a good knowledge of the anatomical landmarks is very important for this surgery. Changing from microscope to endoscope may be difficult and discouraging sometimes. Do not change suddenly. Change slowly. Initially, if you are use the sublabial, you have to move first to the endoscopic assisted with a retractor, and then without retractor. So a slow progress in a stepwise manner brings confidence and ability to tackle complications. So, following the different steps of procedure, some complications could be expected. We will see some of them linked to the endoscopy, and we will skip off the others, the common with the microsurgery, such as endocrine complications, because the time also it's not enough. And they include vascular injury, nerve injury, and nervous system and infection. Among these, the consequences of internal carotid artery injury are the most serious, and its mortality, as you know, and disability rate are very high. So the recognition of important landmarks during each of these stages is the key for safe exposure and therefore avoid the complication. Paulo and Fred show us very well this different step. I will skip it, and I will just talk about some complication. For the first for in the nasal step, for example, we need to avoid injury to nasal mucosa during insertion and removal of instruments. Resultant bleeding can be very frustrating and better controlled by saline infiltration than coagulation. Our protocol to avoid the bleeding, which is used in the common used by the most of neurosurgeons worldwide, we need the cooperation of our anesthesiologist to keep the blood pressure relatively low, around 8 to 10. And the bleeding during this approach is really the great enemy. You know that very well. And sometimes there is a synergy, as you see here in this video. There is a synergy that we can see it in some cases for the first time, because there is some infection before the happening of the pituitary adenoma, but more frequently we see it after reoperation, and we should to cut it with the monopolar and not to cut it sharply, because it can be recurrent if you cut it with the knife sharply. So learning the approach requires collaboration. I already said that, with the ENT, who are more used to preserving the nasal structure, reducing the risk of complications, and facilitating the possible surgical revision, avoiding injury to mucosa during insertion and removal of instrument. And I have to say, I remember when I have started my neurosurgery 30 years ago, assisting some surgeons with an important injury of mucosa, and have seen a patient after following them years after, while I with a huge complication like emptying the feeling like empty nose, described by patient as unbearable and difficult to breathe. And this approach could be a frustrating experience in the first 20 and 30 cases, because of difficulty in initial phase of procedure, which can be minimized, overcome, or avoided by knowledge of endoscopic equipment, detailed understanding of endoscopic perception of anatomy, learning endoscopic skills, and knowing tips and tricks. Microsurgery is like eating with fork and knife. Endoscopy surgery is like eating with one chopstick in one each hand. So we can learn this approach only with commitment and dedication. The second stage, the sphenoidal stage, in this second, it means sphenoidal. In my embolic experience, the surgeon and assistant act as a team, as a pilot and co-pilot, better than fixing scope in holder It provides better perception in this step. I'm completely agree with Paulo when he said that. And first of the bone plan, a scanographic study being derived to avoid the traps of apneumatization of sphenoidal sinus. In most cases, you know, the sphenoidal sinus is largely pneumatized and access to stellar floor is not a problem. However, in some cases in sinus, the sinus is partially pneumatized and are not at all, which requires use of drilling and makes useful the use of neuronavigation. And it is also indicated in the early cases, the giant tumors and the kissing carotid, for example. And a good study of per-operative imaging can anticipate this kind of problem: assessment of size of nasal airway, deviation of nasal septum, anatomical variation of nasal pathway, sphenoidal sinus, sella, etc. So the first complication complication, in my opinion, is when we are faced multiple septa and the sphenoidal sinus may distort the perception of the midline. And this is one of the first cases in my series where the procedure was stopped and switched to microsurgery because of the difficulty of visualizing the stable anatomical landmarks, optical nerves, carotid, etc. And at that time, we didn't have neuronavigation. Recognize the anatomic trend endoscopically, the two optic nerves of the superior part and the two superolateral internal carotid and two sinus cavernous laterally, and also morphological study in MRI is in pathological situation is very important. And we see our colleague from Japan show us for this case, I don't go to the sinus cavernous sinus. I just perform partial removal of the tumor and send the patient to radio surgery, because I never I don't have experience with surgery of cavernous sinus. This is another case, very interesting, because it's a woman for 67 years which had a severe visual defect with non-functional pituitary adenoma, and the MRI showed the infiltration, the invasion of the left cavernous sinus. And we have the fun spotting with my colleagues, the carotid on the preoperative plan here, especially in the left and the neighbor structures. So this is the video of these patients. The opening of the sphenoidal sinus sometimes require a drilling to better see the anatomical landmarks. You see here, of course, the vomer, the rostrum, and there is we use the drilling because it was very very strong. And sorry, it's yeah. Here is the sinus is open partially. We continue the opening with the Kerrison, and I go next one. So here is the image in front of which we found ourselves during the opening of the sphenoidal sinus, of the unrecognizable anatomical landmarks. It's thanks to the neuronavigation that we had the audacity to open these septa here to find the midline and the stellar floor. You can see here the proximity of the two carotid by looking at each time the neuronavigation, and therefore the damage of carotid injury is very important because the venicity and the proximity of the two carotid. The sphenoidectomy, usually in this approach, we need to be enlarged immediately and afterwards to avoid erroneous entry to anterior cranial fossa. And sphenoidectomy usually is made as a V-shaped from both ostia by diamond drill, as I told you before, or removed at a single piece, as you see here, and then the open of the cellar, and you see here the dura. So you can see also the cellar floor after drilling the various septa here and tracking by neural navigation of the midline and the imprint of the two carotid. You see it here laterally, and when you executive in and out movement inside the nasal cavity to judge the depth and to fix surgical landmarks, we need to be very careful, because we example in some cases without navigation. In this case, we can't. Okay, we can't move more. At not properly oriented Doppler or navigation, helpful must be recognized immediately and treated by endovascular stent. You must, when you are in front of carotid artery injury, I think you have to first calm down and then pry if there is an endovascular radiologist available, control hemostasis either with the cotton wool and take muscle nearby it the situation, allow it, then packing on all and call to of course the endovascular to tackle this complication. Carotid artery injury is the most feared and potentially catastrophic intraoperative complication, and an endoscopic skull-based surgeon may face. With the advancement of transnasal endoscopy surgery and the willingness to tackle more diverse pathology evidence-based management of this treating complication is paramount for patient safety and the surgeon confidence. Review of the when I reviewed the literature, we found the incidence of this complication in endonasal skull-based surgery to be as high as 9% in some surgeries. Furthermore, current treatment recommendations can result in damage to critical neurovascular structures. Management decision must be made in the pre-operative, operative and post-operative setting to ensure adequate treatment to carotid artery injury and the prevention of its complications such as pseudoaneurysm in phases should be placed on a surgical competency, teamwork, and the technical expertise through education and the training. Don't forget this image. It's really one of the image, the panoramic view mimicking a fetal face. You don't go over if you don't have this image before and control and have all the anatomical landmarks. So here, the neuronavigation is very important in many situations for the beginner. Early cases when they have a sphenoidal sinus anatomy not straight, precellar or concal type, or multiseptal, as I show you, an extended transsphenoidal procedure in the giant tumor, as Fred showed us, you have to pass the scope in the nostril inferiorly 25 degrees to choana first. And choana, you know, is an anatomic reference. And then go up between the inferior turbinate, middle turbinate, and septum. Paolo showed us very well this step of procedure. And the scope is held upper part of nostril. The four-minute instruments are passed below the scope through a lower part of nostril, and keep checking proper orientation is very important. Buttons of endoscope are facing off the screen all the time, and especially after each exit and insertion. Midline identified by remains of rostrum, vomer inferiorly, and stay between the carotid bulges. And if you have problem, don't hesitate to use the neuronavigation. So when we are face reoperation, I will share with you these cases. We pass scope on the nostril for 25 degrees to choana, as I said before, and we try to find the midline to identify by remains of rostrum, as I said to you, vomer inferiorly, and then we have to stay between the two bulges. Here we don't. I pass by the see how the situation, where is the some anatomical landmarks, and I was really obliged to use of course the neuronavigation to identify the midline. And then here you see after identify the rostrum here, and then we identify finally the dura, which is a very fibrosis. You see here I'm trying to cut it, but it's not easy. And finally, of course, continue the operation with the removal of the tumor. The next one is the cellar stage, is the last one. The opening of the dura first is very important. The endoscope knife is used to cut dura in the center of from periphery to midline, not midline to periphery, as with the long handle of knife. Precision is not very accurate and can injure cavernous sinus. Or use precision grip scissor to extend dural cut on the side after initial central opening with the endoscope knife. Opening is extended caudally and obliquely toward 5 and 8 o'clock position, creating inferior flap, and cut dura only, not the tumor capsule. Dissect dural flaps from the tumor and reflect them outside. Basal and posterior part of tumor is removed from opening the inferior flap in a posterior trajectory toward the clivus and the dorsum sali junction in caudal to rostral direction, first to avoid to remnant and normal tissue of pituitary gland. So the cellar stage, okay, I will go faster. The cellar stage start by this. I will use this video first. Maybe this one. Start here. Okay. So the cellar stage start by pushing the diaphragm with the cottonoid and remove tumor using a curved situation from recess and recess under vision with the angled scope. Bimanual dissection of capsule. section forceps in left hand and for gentle retraction, and precision grip forceps in right hand for counter traction and dissection to peel away arachnoid of adherent normal structure. So I think I will go faster because the pulsation, when the pulsation is visible in the diaphragm, is the robust finding that there is a total tumor removal. If arachnoid tear occur, prevent further opening of arachnoid. Small tear should immediately be seated with the glue and keep one patty to cover to prevent blood going in a subarachnoid space and causing vasospasm. So the last stage is the reconstruction stage. I think Professor Paulo Cabawenga told us many things about that. So I just maybe tell you that there is if there is the CSF leg persists, we need to, in our experience, we reoperate immediately. The 3F that he said is very very judicious, and meningitis is, as you know, a dangerous complication and has an incidence of 0.4 to 9%. Certainly, a postoperative CSF leg is an important risk for factor or for meningitis after surgery. In addition, the presence of significant preoperative paranasal sinus abnormalities also carries a significant risk for meningitis with the transvenous surgery. Another but rare complication of postoperative CSF leg following this approach is a tension of pneumocephalus and meticulous closure of the cellar, as already said. Defect has been advocated to prevent complication. So in conclusion, all in all, what we can say that the majority of post-operative complication can be avoided by gradual transition from microscope to endoscope. Proper selection of cases in the beginning is very important. Acquiring hand-eye coordination and endoscopic surgical skills in lab on cadavers or assistant experts. Gentle handling of mucosa. I'm always telling to my collaborator, it's very important. Spending time in sphenoethmoidal recess widening and regonation of important landmarks during each stage of surgery is very important, is crucial. B manual dissection and sequential tumor excision under vision, using extended approach in large suprasellar and giant adenoma, as Fred shown us, and image guiding in the first, in my opinion, for 50 cases, and we never required, of course. Mucosal flap in reoperation is mandatory. Avoidance of arachnoid tear, we have to do our best to avoid it, and preservation of normal pituitary. So expertise in both open and endoscopic techniques is necessary for the contemporary skull-based surgeon. And thank you very much for your attention, and sorry to be so long. It's not easy to speak about all the complication of this approach in 25 minutes. Thank you so much.
Thank you very much, Najia. Thank you for an excellent talk. Some really nice practical tips for people who are starting out. And also a nice description about staying calm, which is maybe the most important thing when dealing with some of these complications. Are there any comments from anybody else on the panel? Any questions for our speaker, please? While we're waiting, I'll just ask a question. It's always difficult, isn't it, to try and train to handle serious bleeding like the carotid or anything like that. What are your thoughts, of anyone from the panel? How do you prepare for something like that? If you do enough complex cases, you are going to get some sort of problem. vessel injury, either carotid or...
I had in my career, I think, because I show you, of course, in this series only the endoscopic approaches, about 150, but I had more experience with microsurgery for 10 years before. I have more than 300 cases. I have two complications with the carotid artery injury. The first one when I operate with the microsurgery, I have the chance. I was lucky at that time because I have endovascular surgeon in the room near me, and of course I have some mucosa that I put it in on the injury of the carotid, and some hemostatic and the packing, and then we repair it with the endovascular. And the second one is happened, I think, 2 years ago, and I have also in this time my endovascular just behind me, because I expected before operating that we can have maybe that the injury of carotid artery can be happened, and we prepare the carotid also sometimes in these cases in the neck for in case when we couldn't repair or control the bleeding.
Thank you. Are there any comments from anybody else from the panel?
Sanjeev, I'm driving, so may I ask a question?
Of course.
That I think Prof. Najia's talk was quite good, and lots of pearls of wisdom in there. Especially, I just want to emphasize the importance of landmarks and orienting yourself to the midline and not depending on too much on navigation. I know these days we use navigation for all these cases, and partly it's because we are worried about the medical legal issues as well. But I agree. I think in a primary case, the more emphasis should be on your landmarks, knowing your landmarks and sticking to the landmarks, because even a few millimeters of inaccuracy with the navigation system can land you in trouble. But I think it's quite useful in a recurrent case, and when there is no landmark, it's quite useful. But I think your primary emphasis should be on the your landmarks and anatomy, as Prof. Najia eloquently said. Thanks for the great talk.
Thank you.